Thank you for coming today. So I was given the task to talk about innovations updates in 2025. So we're going to go through quickly the latest insights, which came just like a couple of months ago from TCT, to give us like an overview and a kickstart for GIS of this year. We're going to highlight some of the drug-eluting balloons, IVL, PCI versus cabbage, and if we have time, we can talk about non-STEMI in elderly. But the reason we brought this is basically we have kind of brushed the drug-eluting balloon in the past, thinking that it's an old technology with the presence of stents, but now they're coming back. So this is the innovation number one, that not everything is like old, it's bad. Maybe it's oldie, but it's goodie. And second of all, IVL and talking about it. So not everything that like shiny and look glamorous from the outside means it's the best. Sometimes, no. What you have is already doing the right job. And finally, the final combat between percutaneous intervention versus cabbage is coming to road and maybe an end after 10 years Nobel trial. So this is the review of today's late-breaking trials. It's basically 5 trials. We talked about the de novo drug-eluting balloon, also now the sirolimus drug-eluting balloon, and finally also the ISR, or the bifurcation, and finally Nobel trial. So this is the first trial comparing drug-coated balloon versus DS in de novo lesions, whatever, how you want to pronounce it, cage-free trial. And usually it's aimed to compare the efficacy of DCB versus DES in a long de novo lesion defined by more than 20 millimeter. They have a very complex study flow, but all of their patients have been prepared by successful pre-dilatation, avoiding any significant dissection or compromising the flow or having a visual residual stenosis more than 30%. Then they proceed either with a paclitaxel balloon or a stent. And they found after 3 years, there's no difference in the cardiovascular death. And you can see the charts in front of you. Target vessel MI, again, numerically maybe the DS did better, but again, no significance in difference. But when it came to revascularization of these lesions, DS performed better at 3 years. So the primary endpoint with a device-oriented composite endpoint has shifted toward the favor of DAS driven by revascularization. And in the DCB group, 9.4% of the patients required rescue stents. So it's not like, humongous number of issues. And the failure DCB strategy was driven, as we said just now, with a high rate of revascularization in elective setting. And they found actually the difference over time has, stabilized, suggesting the benefit of DAS that become less pronounced after the initial year. So what is the implication? DCB, even though with rescue stent, they're not as effective as drug-eluting stent, and maybe the stent still the standard of care. And when they looked at it in sub-analysis in the bifurcation, they found the bifurcation group, the risk of DOAC was numerically similar between the two groups. So what are we getting with this? We're getting that you have to plan your case, prepare your patient, and tailor your therapy based on the patient and not only on the device that you have. Going forward with the solution de novo, comparing the strategy of PCI with sirolimus implantation, again in de novo lesions, is basically going with the same, but their endpoint was target vessel failure at 1 year. And they compared both strategies. They have, exclude the high-risk cases, ACS, CTOs, or who have previous PCI on this target vessel. And they have heavily used imaging in these cases. And they have achieved an inferiority margin in this case, even though that they had almost 70% of their patients, or 33 in number, within bleeding risk and ACS. And 18 also had 19 in the LAD, vessel diameter size more than 3, and even the calcification was 22. So they have achieved this, and they have a nice results up to 1 year. With again, we're talking about DS maybe doing a bit kind of better, and there is no much of difference between them. Nevertheless, it's been limited. This limitation has been considered in this trial. The lesion proliferation, they didn't really open and utilize lesion modification in these cases, and it's performed with solution DEP rather than the standard paclitaxel that all of us have. So 80% treated with solution did not require stent, and these result with broad inclusion criteria applied to significant segment of PCI. Still, we have 5 years to go forward. So the strategy of PCI and provisional DES was non-inferior to each other's. When you go for the solution ISR, which is the same, now going the same concept, but in instant restenosis, again, they had a randomized multicenter, single-blind active control and inferiority trial. So they brought the patients who have ISR, and then they compared them to the standard of care, depending on what you have in your center. And again, they have used significantly OCT in these cases, and compare them to DEB. I will not go through the exclusion-inclusion. We will just go do it for the sake of time. You will see that at the first and only they demonstrate non-inferiority against the standard of care, and it's safe and effective alternative, and without any additional layer of stent, giving us the thoughts as we're talking in the structural lifelong management. Now we're talking lifelong-term management in stent intervention. So PCI will continue to evolve, demonstrate robust clinical outcome with a reduction in the need of permanent stent implantation, and sub-analysis will further inform how drug-eluting balloon will shape the future of clinical practice. Large real-world clinical experience would provide understanding in specific lesion and patient segments. We're coming round and round again about tailoring your management according to your patient. So shifting gears from DCB to high expensive IVL. So we have two trials now, the shortcut and the victory trial. We're comparing the IVL versus other method of lesion modification, as in cutting balloon or OPM balloon. And both of them have almost the same answer. They have evaluated the safety and efficacy of these products in moderately to severely calcified lesion. And whenever there was a discussion, what is the definition of calcification? That's their definition. It's to have a radiopacity, both sides, longer than 5 millimeters, with either 360 arc or 270 calcium arc. And they have compared the cutting balloon versus IVL, and they had a strategy success and in-hospital 30-day MACE. And they were looking at how much of MSA achieved at the most calcified area. And they found at the end of the day, there is no much a difference. Maybe the IVL had the advantage of 1.1 expansion. But in other words, the cost was significantly higher in the IVL in compared to the cutting balloon, which is significantly. There are though limitations that all procedures were guided by intravascular imaging with experienced operators. So we're coming back and talking about imaging. Cutting balloon therapy was delivered directly by protocol, and it was undersized by 0.5 in comparison to the vessel diameter. An angiographic outcome beyond the procedure conclusion clinical outcome beyond 30 days were not tracked. So we don't know what's happening after 30 days. So cutting versus IVL regarding minimal stent area in the site of the maximum in the total study population, there was no difference in the expansion in the presence of calcium fracture and strategy success and intraprocedural event out to 30 days between IVL and cutting balloon. So again, there is it's less costly option when compared to IVL for the treatment of significant calcified lesion treated with imaging guided PCL. And then Victory, they did basically the same again, but using this time the supra-high pressure non-compliant balloon. Again, they have been utilizing significantly OCT in this trial. And you can see even they have excluded patients with renal failure or have significant tortuosity that they cannot reach there. And they basically reach to the same concept of non-inferiority. OPN was non-inferior to IVL in the terms of stent expansion, indicating they have the same safety profile. And finally, in the last 2 minutes, we're going to talk about 10 years mortality outcome in Noble trials. Noble trial came when I was out, maybe I'm not even a fellow yet in the intervention. And it was all it's a negative trial, cabbage rules. But now we're looking after 10 years of Noble trial, looking into it, which is amazing to track patients after 10 years, see that all causes of mortality didn't really differ between both arms in cabbage and PCI. And even in mortality and time-dependent landmark analysis, and even in subgroup analysis. But this is like, the shocker was for me, in acute coronary syndrome, PCI did better after 10 years. It has not been reflected with the syntax score, even up to high syntax score. But here's the kicker. IVUS-guided intervention, they did even better than CABG. So what is the notion that we're having from the last 4 or 5 things that we're mentioning? We're talking again and again, image-guided, assessment, follow-up. After 10 years, with all the technology that we had 10 years ago, IVUS was prevailing with all its limitation. So PCI versus CABG, similar in all causes of mortality in 10 years, there's no difference. But in ACS, PCI was associated with lower mortality. Syntax score has no association with mortality. So what are we getting here now? We're getting that not every patient should be tailored the same way that you want to tailor it, because you have some fancy stuff, new stuff, you're going to put it in your patient. Tailor your management based on your patient himself and his background or her background. Utilize imaging as much as possible, not because you don't have IVL, for example, or an expensive equipment in your cath lab doesn't mean that you're not going to have good results. Maybe some simple stuff can take you an extra further away. So to sum up, in the last 30 seconds, these are the trial. I mean, if you're going to get out from this room, you just take a snap picture. We talked about all of these in terms of, de novo, drug-eluting balloon, in terms of the ISR, IVL versus cutting balloon, IVL versus OPN, and finally, Nobel 10 years. There is still hope for PCI after all this. Thank you for your attention.